non-invasive positive pressure ventilation. That's BiPAP, but they don't call it BiPAP on the exam. They call it that, or maybe they can call it NIV, non-invasive ventilation. Okay? What is an NIPPV? It is a special type of therapeutic ventilator used for non-invasive ventilation. Non-invasive means it does not require an artificial airway. You cannot hook up BiPAP to ET tube or tracheostomy tube, okay? Because it's non-invasive ventilation. NIPPV can be used to treat both acute and chronic respiratory failure. Okay, so remember this now. Example, partially compensated respiratory acidosis. Okay? With PaO2 less than 70, that's very important, because if the PaO2 is greater than 70, then you have to assume that what is causing the acidosis is too much oxygen. Okay, so this is acute and chronic. So let's say that this patient was initially like this. Compensated respiratory acidosis. Okay? That's the normal class. Now, COPD is this way. You can still use BiPAP and then to maintain their normal ventilation. Some of them will use it. But now they get sick, they go like that. That's an acute problem from this. All of a sudden, there is a change in what used to be normal. That's what acute means. Okay? And I'm going to give you another example here. How about 7.35? No, 7.3, let's say 32. And then you have CO2 that is 47. And then you have PaO2 that is 65. And then we have 23. Uncompensated respiratory acidosis. Now, usually this type of patient, you will be intubating them because they're having an acute problem. But the fact is that the CO2 is not very high. It's only 2 points above normal. So this type of blood gas will not really necessitate intubation, especially at the hospital, okay? Because now intubation carries a lot of consequences, okay? When you intubate somebody, you can lacerate their tongue, you can damage their vocal cords, you go down there with ET tube, you are introducing more bacteria down into the lower airway. You may never get them off the ventilator, and then they may get, wind up getting trapped, and they start harm. So we want to avoid some of that. So sometimes when we have something like this, okay, they don't give you a choice to intubate and ventilate. You got to put them on BiPAP. That saves the patient a whole lot of problem. Okay? So, but look for intubation first. If you don't see it, then you can do that. Okay? All right. Positive pressure means it delivers a prescribed pressure with each breath. Now, this is pressure ventilation. BiPAP is pressure ventilation. So everything relevant to pressure ventilation will hold with the BiPAP. For instance, if a patient is on BiPAP and their lung compliance decreases, or maybe airway resistance increases, the exhale tidal volume will go down, and vice versa. Okay? NIPPV has one pressure for inspiration and one pressure for exhalation. The inspiratory pressure is called IPAP, inspiratory positive airway pressure. Okay? It's like your PIP on the conventional pressure control mode. It's like your PIP, setting your PIP on pressure control. The expiratory pressure is called EPAP, expiratory positive airway pressure. It's like your PEEP on the ventilator, or your CPAP. So I've told you many times, EPAP, CPAP, and PEEP are all the same. Okay, a PEEP of 5 equals to EPAP of 5 equals to a PEEP of 5. The indications, the contraindications, and complications of those three are all the same. Okay? We'll call it EPAP when somebody's on BiPAP. We'll call it CPAP when somebody's breathing spontaneously. Even if they're on the ventilator, but they're breathing spontaneously, like on pressure support, you will call that positive pressure CPAP. But if the patient is not breathing spontaneously, then we'll call it PEEP. But they all do the same thing. A breath rate can be set, yes. Now this is a spontaneous mode. BiPAP is spontaneous mode. BiPAP can never be indicated for somebody who does not have any spontaneous breaths. You can't. If the patient is apneic, you're gonna have to ventilate them, intubate them and ventilate them. But before you can be put on BiPAP, you have to be breathing spontaneously. But we set a backup rate in case while the patient is on it, they go apneic. So that's why we're setting that backup rate. Then the unit will take over and start ventilating the patient with however many breaths that you set. And we set the rate very low, from 4 to like 8, at most 10. Okay, because now, if you set it up to 10 or above 10, you are actually breathing for the patient. Okay, so the entire purpose is defeated. Okay, so that's why we set a very low rate, so that the patient can breathe on their own. Okay? So IPAP, oh no, over here. When the patient starts to inhale, the machine takes over the work and sends the patient a breath until the prescribed pressure is reached, which is your IPAP. After that pressure has been delivered into the patient's lungs, inspiration will end. Okay? Now the unit only uses oxygen. Okay? You plug it into an oxygen outlet, and then it kind of like pulls air, okay, into the device. Okay, it pulls air into the device. Okay? So IPAP and EPAP equals BiPAP. So here's IPAP again, the amount of pressure delivered to the airways during inspiration. IPAP increases lung volume by providing positive pressure. This reduces the amount of work the respiratory muscles normally do to increase volume. So at any given time on a BiPAP unit, if you want to get more volume, you increase your IPAP. If you want to get less volume, you decrease your IPAP. Okay? You can also do that with the EPAP, but I'll tell you in a minute how you can do that. But the main thing is IPAP. EPAP, positive pressure maintained in the airways during expiration, like PEEP, the amount of pressure left in the lungs at the end of exhalation. Minimizes or eliminates upper airway resistance and small airway collapse, frequently present in patients with COPD, especially during sleep. Now, if I wanna use this unit now, somebody who has OSA, obstructive sleep apnea, yeah, I could put them on CPAP. I can set them up on EPAP. They are doing the same thing, because EPAP is the same thing with CPAP. I'll cut my IPAP off, and then I'll set them up on the level of EPAP. Okay? All right. The difference between IPAP and EPAP is called pressure support. That's the delta P. Delta P is what we call it. Okay, so right here, the delta P is 9. So take 6 away from 15, you got 9. So this is the pressure that actually gets the volume. The bigger the delta P, the higher the tidal volume. The lower the delta P, the lower the tidal volume. Okay? So now, if you look at this now, to increase this delta P, I can increase my IPAP. Okay, let's write it down. So right now it's 15 to 6. My delta P is 9. Well, if I go up to 20 on this one here, and leave this one here 6, my delta P becomes 14. So this patient will get more tidal volume. How about if I get my IPAP and go down on my EPAP to 4, my delta P becomes 11. So in some cases, you can increase delta P by decreasing EPAP as well. Let's say that the patient has too much oxygen. Okay, that's PEEP. They have too much oxygen and you want to reduce their oxygenation. Okay, well, you can decrease their EPAP. Once you've done that, that increases their delta P and causes them to breathe a little faster. Like in COPD patients. Okay, if I had a patient like this, let me give you an example. Let's say I have a patient like this. Okay, and the BiPAP. Well, they're getting too much oxygen here. That's the problem. So now, if the patient is currently under 15 to 6, my delta P is 9, right? Well, I know that I need to take away some of the oxygen here. So I can decrease my EPAP. So if I go 15 to 3, what I got is 12. So that decreases the PLO2 plus increases ventilation because now you're going to start getting more volume to blow off this CO2. So sometimes you can use EPAP and fix two things on a COPD patient. Okay? That's the one that many that will have on the exam because it's very tricky. Most people will want to increase the IPAP on this, not paying attention to this. Okay? All right. So now you notice now that what actually determines delta P is where you have the IPAP and the EPAP set. Not necessarily that the IPAP has to be very, very high. Like here, we only have IPAP of 14 and EPAP of 4. The delta P is 10. But here we have IPAP of 15 and EPAP of 6. You know, we have delta P as 9. So it's just the difference between the two. Okay, the higher the number, the higher the delta P, and the more the tidal volume that the patient is going to get. EPAP cannot be set higher than IPAP, and that is correct. Before you can actually say that somebody's on BiPAP, the IPAP has to be at least 4 points greater than the EPAP. At least 4 points. Yeah? If you set it on the same level, you are actually on CPAP, not BiPAP. Let's say if I said IPAP of 15, EPAP of 15. Well, I'm not on BiPAP, I am on CPAP because it's one level of pressure. Okay, one level of pressure. Okay, so for that first one there, let's say that this is your lung unit here. You already got it says that EPAP cannot be set higher than the IPAP. Okay? If I have, let's say, EPAP of 25, no, I got it backwards, sorry. EPAP is down here. And then I have, let's say my IPAP is 10. Okay? That would not work because the lung unit is already opened up. It's like you getting like a container full of water, a bucket of water, and then you're putting 1 drop of water in it. It's not going to make any difference. And you put 1 or 2 drops in that big container of water. It doesn't, you won't even notice anything. Okay, so that's kind of what this here is telling you. The lungs are already opened up. If you add 10 more, it's not going to do more of this. Okay? So the IPAP has to be always greater than the EPAP. Okay, so the circuit. On this one here, we have 1 circuit for inspiration and exhalation, unlike the ventilator. Okay? There's just 1 here. The air comes out from here and goes to the patient. When the patient exhales, it doesn't come back to the unit. Okay? This is called the proximal airway line. That's a feedback mechanism to the unit. This is how you measure your mini volume, your tidal volume, and all of that. If this is taken off, then you will see most of the display on the screen. So that's proximal airway line. The expiratory port is right here. Okay? When the patient exhales, the exhaled air will go out from here. So at any given time, whenever you block this, number 1 is that they can't exhale, and secondly, their arterial CO2 will rise. Okay? If it's not on the mask, sometimes it will be down here. Oh yeah, like it's right here. Okay, now, so you can have 2 of these. Okay? This is exhalation port, this is exhalation port. Now, if you have a mask that has exhalation port like this one here does, then you're gonna have to take off this little piece, because that will cause the leak to be too much. Okay, patient leak. Or if you have a mask that doesn't have exhalation ports, then you have to make sure that you have this, but you can have both of them. Okay? So the patient will be leaking at most of the volume, and then the CO2 will not be impacted as much. Okay, so it says 1 circuit line for inspiration. The inspiratory circuit line may have an exhalation port at its distal end, or the exhalation port may be a hole somewhere on the mask. Okay? Proximal airway line, I've already shown you that. That's how you get your exhaled parameters. We can use face mask, we can use nasal mask, we can use nasal points or philos as interface, to deliver this. Each one of them has advantages and disadvantages. So we're going to do the nasal mask first. Advantages: easy to feed and secure to patient's face. Okay, it's just covering their nose. Okay? No matter how big your nose is, we're going to find one that will fit. Less feeling of claustrophobia. Yeah, that's true. Some people just don't feel well when you cover their nose and their mouth and their face. They don't feel good about that. But if you're just covering their nose, well, they can still see if they need to open their eyes. Low risk of aspiration. If the patient throws up, they can still spit out the vomitus through their mouth. You are not blocking their mouth. So there is less risk of aspiration pneumonia. Allows patients to cough and clear secretions. Yeah, they can cough anytime because the mask is on their nose and clear their airways of secretion. Maintains ability to speak and eat, yes. they can talk to you, okay, they can eat. Okay. Less mechanical dead space. Yeah, remember the bigger the airway, the more mechanical dead space. Well, it's just going in through the nose and coming out through the mouth or through the nose. So less mechanical dead space. Disadvantages, mouth leaks. Now, some patients go to sleep and they go like, their mouth is open, right? Well, you know, close your mouth. There's something we call a chin strap, okay? If you get a patient like that sleeps like that, then, you know, we get that chin strap and say, please close your mouth. We'll close their mouth, you know. So that, because now, if their mouth is open, the pressure is coming out from their mouth. So their tidal one will go down, and their CO2 will begin to rise. Eye irritation, so you have to make sure that you size the mask. I think they have small, medium, and large. Okay, size it very well and make sure that if the patient is going to wear small, you're not giving them large, because then that will cause air to begin to get into the eyes. Okay. Facial skin irritation. Okay. That is usually because of how tight you have the strap. Okay. If you have it very tight, then that can mess up their skin in the area that the strap is touching. How you test that is that once you put the strap on, see if you can get a finger underneath it, okay? If you cannot get a finger underneath the strap, it's too tight. That's the way to test it, okay? Ulceration over nose bridge, the same thing. That will cause that. You have the mask very tight. Oral dryness, now they're using humidifier to do that. That will take away some of that. Because you know that oxygen is anhydrous, meaning that it doesn't have any water vapor in it. So it will dry you up, okay? But, you know, they have humidifier that they can mount right here, and then let the air pick up humidity before it goes to the patient. That will decrease some of that. Nasal congestion, yeah, all that pressure going inside the nose, okay, may cause congestion. Increased resistance to the nasal passage, yeah. Now, full face mask is where you have the mask covering your nose and your mouth, okay? It reduces air leakage through the mouth, yeah. We want to cover their mouth and their nose. Less airway resistance, that is true, because the air is going in through their mouth and through their nose. So it's like the airway is bigger, so there will be less resistance. Disadvantages, increased risk of aspiration. Yeah, if the patient throws up, they can't spit it out because you're covering their mouth. The air comes back and then pushes the whole thing back into their lungs. Increased risk of asphyxia. Yeah, you cover their nose and their mouth with this, and then you went to lunch. Something happens to the unit, it stops, okay, or you know, blocks from the wall. Well, the patient can't get any fresh air. Okay, but if you just hide it on their nose, and that happens, they can breathe through their mouth. Okay. So in most cases, when somebody's going to wear full face mask, they have to be in an area where they can be monitored. Okay. Usually in the ICU area or close to the nursing station. Okay. As claustrophobia, difficult to secure and fit. Now some patients just have long head. Their head is kind of like oblong like that. And then even if you get the biggest size, it's about right here. Okay, it doesn't completely cover everything. Skin irritation, if it's too tight, ulceration of the nose bridge, if it's too tight, patient must remove mask to eat, speak, or expectorate, which is really bad in some patients. Let's say you have a patient that is very, very hypoxemic, okay? And you have them on full face mask. Well, they need ice. They are actually for ice. So, or maybe you want to feed them with something, or maybe you want to give them MDI. So you're gonna have to take it off, and then if you're doing MDI, you squirt it down, and then you put it back. Okay. If you're feeding them the same way, okay, remove it, here's your food, and you go, okay, okay, I'll take it off now. Okay. So doing that off and on, it can cause your oxygenation to go down. Okay. Nasal pillows or nasal prong. Advantages, same as for nasal mask, facilitates communication, they can talk, less feeling of claustrophobia, low risk of aspiration, allows patient to cough and clear secretions, low risk of carbon dioxide rebreathing. Okay, the dead space is low. No headgear. Sometimes they don't have the strap with the nasal point. You just put it in their nose and that's it. Disadvantages, pressure sores around the nares, nasal air leakage, hypersalivation, possibility of orthodontic deformity. Patient selection, don't worry about that. The formula is partially compensated respiratory acidosis with PaO2 less than 70. Anybody can get BiPAP. The only time that a patient will not qualify for BiPAP is when they have ARDS, or maybe they have pulmonary fibrosis, or any other condition that causes their lungs to be very, very, very stiff. This is spontaneous breathing. If they have very stiff lungs, we want to intubate them and ventilate them. Okay. Otherwise, if you have impending respiratory failure, you're compensating, we're going to put you on BiPAP. That's all you got to remember. Okay. One thing here also about the OSA, obstructive sleep apnea. Let's say that we have a COPD patient that has OSA. Okay. Well, normally we use CPAP for OSA, but now they have COPD. Remember, CPAP is PEEP. So if a COPD patient has OSA and you put them on CPAP, their PaO2 will go through the roof. Immediately they're going to become very lethargic and go to sleep. So when we get a COPD patient that has OSA, we use BiPAP, not CPAP. Remember that. We use BiPAP. In that way, they can still be ventilating, controlling their CO2, while the EPAP is splinting their airway. Okay? If they don't have COPD, then you can use CPAP. Okay? Any questions about that? It's good for pulmonary edema. Any kind of pressure, not just that, any kind of positive pressure, PAP, is good for pulmonary edema. And CHF, because that pressure causes the fluid to go into the lung tissues. Potential benefits, avoidance of endotracheal intubation. Yeah, like I said, intubation carries a lot of complications. So anytime we can avoid it, we avoid it. That will save the patient a whole lot of problems. Okay? So it's not like you will never intubate somebody who has partially compensated respiratory acidosis with PaO2 less than 70. But the first intervention is BiPAP. But then if the patient is not improving on that, then you can intubate them. Decreased duration of ventilation, decreased incidence of pneumonia. Anytime you shut down that ET tube, down into the lower airway, you've caused infection. That's how people get VAP. Okay, I'm yet to see any patient on the ventilator that doesn't develop VAP, ventilator-associated pneumonia, because you drag bacteria from their upper airway down into their lower airway. Even if they don't have it, the doctor will put them on some kind of prophylactic antibiotic. They usually get it 48 hours after that.
So it's inevitable that you're going to get it.
Say that again?
It's inevitable that you'll get that.
Yeah, it's almost, if somebody goes on the ventilator, before they get extubated, they will be on some kind of antibiotic. There must be, okay? So, if you're doing this then, you're not going to intubate them. So that's why we have low incidence of pneumonia, because pneumonia is lung infection, okay? Decreased incidence of sinusitis, improved ability to communicate. Well, on the ventilator, you can communicate because of the cough on the ET tube. Once we intubate you and put air inside the cough, you can speak. What causes us to speak is expiratory flow. When you are breathing out, that's when we speak. Expiratory flow. When you exhale out, the air coming out from your lungs causes the vocal cords to vibrate. And then you talk. Okay? So here is a question, about the exam question. You walked into a patient's room to do a vent check, and you said good morning to them, and the patient responded, good morning. What would you do?
Freak out. Freak out.
Freak out, right? What do you think caused that? Are they supposed to talk?
Extubation.
No, you're going to add more air to the cough. Your cough is not well blown up. That's why the patient is able to speak back to you. Okay? Just remember that. Ability to eat and drink, we can do that on the ventilator. Decreased need for sedation. Yeah, that's spontaneous breathing. They need to stay awake. Shortens hospital stay. And that is true, because once you intubate somebody, man, you cause a lot of problems. It's not expensive. It's very expensive to take care of ventilator patients in the ICU, because some people go, well, we got plenty of patients, yeah, our business is good. No, business is bad when they're in there, because Medicare only pays about 60 cents to $1. So the hospital is actually losing money when they have a lot of patients in the hospital. Okay? Another name for the ICU is expensive care unit. Look at all the people that work in there, all those nurses, you know how much they make an hour? Respiratory therapists, everybody. It will cost about $12,000 to stay in the ICU for one day. Very expensive. Preserves airway defenses, improves duration and quality of sleep, improves functional residual capacity, and that will be because of your EPAP. Potential risks: facial skin necrosis, the thing is too tight, and then we are leaving it there, they have to wear for days. Increased aspiration risk, increased duration of ventilation in patients who fail Nippv, difficulty providing adequate calorie. Yeah, they don't eat very well, Just think about it. It's somebody that somebody that is wearing a full face mask and you have to feed them. You're doing this, you remove it. As soon as their O2 saturation begins to drop, you stop, because you can't continue. So they don't feed very well. Decreased ability to cough, okay? And that's because of the pressure, okay? Contraindications, you see it here. Remember ARDS. If they have ARDS, you are going to recommend, as they say it on the exam, you are going to recommend an alternative means of ventilation. That's the way they word that. And that means that you're going to have to intubate them. That's what it means. They're just trying to be funny. So instead of saying, well, intubate them and ventilate them, they say, well, recommend alternative means of ventilation. And then you're thinking, what is that? But that's what they're talking about. How about airway dysfunction? That's another big one here. Dysphagia, inability to swallowing with pain. You're also going to recommend an alternative means of ventilation. You're going to have to intubate that patient because the air is going to, some of the air may be going down into the esophagus, causing them to be in pain. Fixed anatomic abnormalities of the nasopharynx, like the corneal atresia, where the membrane didn't disintegrate at birth. Prone to pneumothorax or pneumomediastinum. They think they're going to have pneumothorax, you avoid it. Okay? High risk of aspiration, you don't want to avoid it. Hypotension, remember this is positive pressure. Any kind of positive pressure will decrease venous return. Whether you're doing easy PAP or a cappella or PAP, period. Decreases venous return and then decreases your blood pressure. Recent facial, esophageal, or gastric surgery. Gastroesophageal reflux disease. This is where some people have that, stomach content begins to work up, and then finally goes into the lungs. Okay. I've never had it before, but they say that your stomach acid. Sometimes you may feel like you're having a heart attack. Okay. On cooperative patients, craniofacial trauma or burns, nasogastric feeding tube, that doesn't cause the mass to fit well. Like if you have something hanging out here, and then they want to put this over it, it doesn't seal very well. So the patient may be losing some pressure. Okay? Massive obesity, that will not do it. Obesity, you know what obesity is? If you're like 500 pounds, there's nobody here that weighs 500 pounds. I'm as big as Brian, but we don't weigh 500 pounds. When you're that big, your body weight, your stomach and all of that will put weight on your diaphragm. You can't breathe. So this is spontaneous breathing. If somebody cannot breathe well spontaneously, they may not do well on the BiPAP either. Okay? Unable to tolerate interface on motivated patients. Frequent complications, gastric distension. I didn't spell that well, did I? I think it's supposed to be an S. It's supposed to be a gastric distension, or sometimes they call it gastric insufflation. This is where air will go into the stomach. Now, the esophageal opening pressure is 25. Everybody try to swallow. You swallow. That pressure you feel, that's 25 centimeters of water. So if somebody is on BiPAP and you put them up to like IPAP of 30 or above 25, then there is increased tendency for the esophagus to open up. And then air will begin to go inside the stomach. Okay, so most of the BiPAP units will only go up to like 25. Some of them may be 30. But anytime you exceed IPAP of 25, that will likely happen to the patient. Now, if your patient begins to complain of stomach cramp, they feel bloated, well, you don't discontinue the therapy. What you do is you modify the therapy. So what you're going to do, you turn down your IPAP. Okay, you turn down your IPAP. until they don't feel that way anymore. Pneumothorax, and that's relevant to using high pressure again. Okay? And then hypertension. Blood pressure is going down, they need BiPAP. You modify therapy. You turn down your pressure. Okay? CPAP. Now, CPAP is one level of pressure. Continuous positive airway pressure. That's PEEP. Okay? CPAP can be set in most BiPAP units by setting EPAP. Here. If I want to use this here to set my patient on CPAP, okay, if I put it on BiPAP mode, then I cut my IPAP to 0. And then I set the number of my EPAP, that would be CPAP. But this one here has got CPAP, a mode that is called CPAP. Okay? CPAP maintains airway open. It improves oxygenation by increasing the surface area available for gas diffusion. Indications for CPAP. Refractory hypoxemia. Remember, we're talking about PEEP here. Refractory hypoxemia is hypoxemia that is not responding to conventional oxygen therapy. If try nasal cannula, no. Turn it up to 6 liters per minute, no, it doesn't go. You switch to a simple mask, no. Then you go to Venturi, run it all the way to 55%, no. And then you go to partial rebreather, no. So I'm not responding to conventional oxygen therapy, okay? So once you get there, then you say, well, the alveoli are closed, they are collapsed. So we're gonna have to open them up. You set them on CPAP. If your patient is out on the floor and they have aerosol therapy with the blue tubing going, and they're on FiO2 of 60 there, out on the floor, but their PaO2 is not coming out, right? The next thing for you to do will be to set them up on CPAP. The same thing we do on the ventilator. If they're on the ventilator and I've given them FiO2 of 60, they're not improving, then I institute PEEP. They're already on PEEP, I increase PEEP. The same thing, okay? Out on the floor, on the aerosol therapy, they're up to 60%, but their ventilation is good, it's just their oxygenation. You set them up on CPAP. Sleep apnea. We use it to splint the airway. Okay? Those offending tissues, those tissues that collapse during sleep, we're going to move them out of the way so that air can get inside the patient's lungs. Okay, so on the exam, usually you're going to start IPAP between 10 to 15. Just like we're doing the data line for the vent. Okay, IPAP between 10 to 15 is what they want you to start. But now, the hospitals are different. So, but we're not doing what they're doing at the hospital. And then your EPAP will be 4 to 5. That's initial settings. Okay? And the set rate determines time break. So, like I said, the rate can be 4, 5, 6, 7, actually at most 8. Because once you exceed 8, you're actually breathing for the patient. The patient doesn't really need to trigger anything. Okay? So, one thing I want to tell you about BiPAP unit is that the patient is always in control. The patient has to be triggering breaths above the set rate. They will be in control. But if anything happens, let's say the patient got over-sedated, or for some other reason, the respiratory rate drops below the set rate on the machine takes over. Okay? So any mode that you go on BiPAP, the patient is in control. As long as they are breathing above the set rate, they are controlling everything. Okay? All right, so let's see what we can do here with the ABG. So I'm going to start with Leah. Leah, tell us the interpretation of that blood gas and tell us what you think would be the best thing there to do.
It's a partially compensated respiratory acidosis
Mm-hmm.
with moderate hypoxemia.
Yeah?
They're on an FiO2 of 28%. So I would place the patient on BiPAP.
Very good. You put them on backpack. Bingo. Backpack. Kiara, what do you think about this one here?
Looks pretty good. Oh, except for the PaO2. So that's an acceptable ABG with moderate hypoxemia. So, place on CPAP.
Yeah, we'll put them on CPAP. Why do you think we need to put them on CPAP?
Because they're already on an FiO2 of 65%.
Yeah, that's it. That's it. They're already on 65%, so CPAP is PEEP. We're gonna put them on PEEP. Here you go. How about this one?
This is a partially compensated respiratory acidosis with normoxia.
Mhm.
So I would put them on BiPAP.
Okay, they tricked you.
Oh, yeah.
Look at is that a COPD patient?
Yes.
Okay, so you gotta pay attention to the PaO2 then.
So then I would decrease the FiO2.
You're gonna decrease the FiO2, very good. Yeah, in fact, with that 100, if you know how a COPD's blood gas is supposed to look, they won't even give you a PaO2 of 100. I've never seen 100. They will give you like 73, 75. The cutoff is 70. If they're above 70, they're acidotic. You have to assume that too much oxygen is causing the problem. Because if they gave you that 100, it's a giveaway. Everybody knows that. Yeah, once I recognize that this is a COPD patient, then I will know immediately that that 100 is way too high. So that's why they give you 72, 73, 74. And that way you won't remember. All right. Alexa, okay, so the patient is already on BiPAP on this one here. So what is the blood gas and what do you think we need to change?
It's compensated respiratory acidosis,
Compensated?
partially compensated.
Mm-hmm.
And I would increase the IPAP to 20.
Yeah, we increase the IPAP to 20 because they need ventilation. Okay, don't worry about oxygenation first, you do ventilation first. All right? Chrissy, what do you think about this one here?
It's acceptable acidosis with low oxygen.
Okay.
Mm,
This one is a little tricky.
Increase IPAP to 22, EPAP to 8.
Yeah, that's it. Now look at this one here. Right now, my patient is on IPAP of 18 and EPAP of 4. My delta P is 14. Now the delta P is what controls your CO2. That's what gets your tidal volume. So now, the delta P of 14 is maintaining my CO2 at 43, which is normal ventilation. But my patient has hypoxemia. So now, if I increase the EPAP, let's say if I'm gonna go up on the EPAP to 6 because my patient needs more oxygen, that will decrease my ventilating pressure to 12. So that will cause my CO2 to rise. So what I have to do then, in order to maintain the same level of ventilation, I have to increase my IPAP by the same amount that I increase my EPAP. You all remember this one here? And this is a lot. It's a lot confusing. So you increase now. Let's say that what Tracy said here, we're going to go to a 22 and 8. So that will give us 14. We are maintaining the same level of pressure. Therefore, we're going to maintain the same amount of volume. Therefore, we're going to keep our CO2 to 43. We can't change our ventilation. Okay? Ray.
It's like uncompensated respiratory alkalosis. Decrease the IPAP to 20.
Mm-hmm. Yeah, increase the IPAP, decrease the IPAP, sorry. You're over-ventilating the patient, and it's not oxygen. Oxygen is good. So we're going to decrease the IPAP. All right, so that's it. Brian and Ashley and Stephen, you got lucky. Well, let's take a break.